I'm going to talk about some trickier fractures that required percutaneous fixation that I think the CurvaFix implant really was a benefit and can highlight in this particular um, type of patterns. Since I'm using the CurvaFix, I've really noticed some ease in terms of switching over to CurvaFix from traditional intramedullary fixation for the pelvis. And I think this highlights some of that in some definitely curved intraosseous pathways. And I think there are multiple benefits to the way CurvaFix works, one of which I think is simply just ease of insertion when it comes to a curved intraosseous pelvic pathway. And the other we'll talk about throughout all of our presentations is the advantage of the increased stability that you get with a bent axle type construct. So I'll present two cases. This is the first case, and we'll talk about multiple different pathways. And at the end, please keep some questions in mind if you have any concerns about overlapping pathways or how to navigate that or how to think of maybe even a new pathway we haven't tried, but I'll show you some interesting ones. This is a 76-year-old male newly diagnosed with prostate cancer, had a very low speed MVA, like grocery store parking lot type MVC, and presented in pretty bad shape. He was banged up pretty bad. The airbag deployed. He was having a lot of internal bleeding and had some hollow viscous injuries. And he ended up with me after this initial scout image like this. So he got taken for an X-lap. And at our place, trauma X-laps never really get closed. So this patient came out of the OR packed with an Abathera wound vac on his open abdomen. And then he became more stable, but he wasn't really ready to be closed yet from an abdominal standpoint. After he came out of the OR with general surgery, we were able to finally get some good advanced images, and it shows that he has this LC2 variant where he's got a typical crescent fracture of his posterior right-sided iliac crest, and he has essentially bilateral anterior columns, a very essentially proximal floating symphysis type injury, where rather than we have really rami fractures, you have pretty high root of the rami type fractures with associated inferior ramus. And you have this obviously iliac crest with a little comminuted segment. So tackling this is a little challenging. And it also, you can see through on his upper right image there on the 3D that he has this sort of really complete anterior column component that comes down through the joint. So tackling this for me in the past was I need to work through an open abdomen. Maybe I'd like to smiley face plate this and make it fully stable from supraacetabular corridor all the way around to the contralateral supraacetabular corridor. And then also taking care of that iliac crest can be quite challenging getting that posterior for plating. And if you look at his two-dimensional cross-sectional imaging, I wasn't really wonderfully happy with his right-sided SI joint. I mean, if you look side to side, I think if I were to look at his right side in and of itself, I would have said, yeah, it's probably pretty normal. But if you look at it compared to his left side, it's definitely gapped. So I was a little worried about a subtle SI joint injury too, or at least an impaction type injury to the right-sided sacral ala, giving the actual joint some instability. So in this particular case, I just wanted to highlight some of the uses for CurvaFix and also that every corridor doesn't necessarily need to have curve fixation. In this particular case, I was able to stabilize first that SI joint with just a partially threaded compression screw in the S1 segment. And then just to stabilize, and if I thought I could catch a piece with this particular pattern of the fractured segment at the S2, it was a very close injury. I think I just got maybe a piece of it, but just to stabilize the joint a little bit even further. And then he clearly had the crescent injury, so he had standard LC2 type fixation. Now, in the case, and you can look at the guide wire image on the left, he did not have a straight shot corridor for an intramedullary screw. And anterior column fixation percutaneous, at least for me, has always been a bit of a challenge because the corridor to me is really very worried, obviously, superior penetration of the pubic ramus once you get past the joint and running into iliac vasculature, especially if you don't get a good obturator outlet view and see that true dip in the ramus. You can be out of the bone and having screw threads right up against the iliac vasculature and not even really know it unless you get the right view. So for me, a curved implant, or at least the ability of the implant to take a curved interosseous corridor, is really beneficial in that you can ride within the bone and not have to worry about things I used to do in the past, like bending guide wires to put screws through curved corridors, but then still the implant being straight, and having to work that bent guide wire out of a straight screw. And even in some really osteoporotic bone in particular, I've had bent guide wires pull the entire screw out of the bone. So this is really where it's been advantageous for me, at least early on in my practice, or early on in my usage of this in my practice. And if you look, this is the starting point for a retrograde CurvaFix, retrograde Ramus screw, which I don't do often. Typically, I think this implant does really well for antegrade fixation, and I think it can be a little bulky if not deployed correctly right around the symphysis. But the way this lined up for this particular patient, I think it was best for fixation, the way his incisions worked out, and really navigating around that LC2 screw. I think I was able to get the implant, at least my plan was to get the implant past the fracture and to and maybe around the LC2 screw, or maybe stop short. But to come at it antegrade, I think that would have been a little bit of a tricky angle. So you can see that the start point for a retrograde CurvaFix, I try to keep as posterior or internal or medial into the pelvis as possible so it doesn't cut out the front. And these are some of the pictures of what it looks like driving the wire across this corridor. And I think this really shows, especially in the central and the right image, how not straight that corridor is, and how a curved implant can be beneficial in the sense that using that ball-tipped, curved, paddle-tipped wire, you can really use that ball, especially around subchondral bone and cortical bone, to deflect away from structures at risk and stay intraosseous within the cancellous bone. It's actually really easy to do when you have really healthy, strong bone. This person wasn't that old, 76. I think the blastic metastasis of his prostate cancer probably helped bulk this up in terms of its density a little bit. But this stays in bone very nicely. And I think one of the early tips and tricks of getting this implant to work well for you is that as you're changing your trajectory and spinning the wire to change the angle, you're tapping along as you're doing that so that the vibrations of the wire help spin and rotate within the bone. And you don't just get this coiling effect where the tip is fixed and you're trying to spin and turn and you get a twist and coil on the wire, which can, if you keep coiling and coiling, of course, it will end up breaking. So just a gentle tap as you're spinning, and you can see going from the far left image to the central image where you have essentially a 180-degree turn in that wire, you're able to navigate that corridor. And looking at the far right image on the inlet, you can see that the corridor is also not straight in multiple planes. So this is what it looks like as the retrograde CurvaFix goes in. And you remember he also had a contralateral injury. And because of the way the CurvaFix sits, I was not able to start a retrograde contralateral implant, but rather an antegrade implant as well for the left side. So being able to utilize both retrograde and antegrade corridors in the anterior column is really advantageous, and it flows really nicely in terms of how it fills the column. And what I mean by that is if you think about a 7.3 millimeter screw or a 6.5 millimeter screw or a smaller than 3.5 screw, you can cannulate the corridor, but are you filling it up and getting that intrinsic internal fixation that you would also get, for instance, with an intramedullary nail when you get isthmic fixation? And I think with this implant, you definitely can add that to the fixation repertoire of this implant when you can fill the corridor up. It also helps with reduction and it makes it quite stable. You'll also see that with that anterior column screw for the left side of the pelvis that's going antegrade, you can get quite distal and medial into the pubic body. And ideally, you can actually curve and come down and come a little inferior down the pubic body to really make a bend in the implant and gain additional stability. So this is what some other views look like. Now, the previous pictures for this case were while the patient's abdomen was still open. So I didn't want to do any open fixation while his abdomen was open. So knowing that I can get these tough corridors as well with a curved implant was very nice. And in this particular case, I think you can see how the retrograde implant overlaps with that antegrade LC2 screw. Or rather retrograde LC2 screw. And then also once his belly was closed and he was stable, this was on a second day back to the OR, I was able to plate his iliac crest just to augment fixation. So these are his images at 6 months. He's a little further out at this point, but you can see the ability to really capture a very curved corridor. Both of those implants are not straight, and you can imagine potentially having a significant issue getting a straight screw through those corridors. The other thing that this really benefits from is the stability that's intrinsic to what I've previously stated, and I've talked to some other people from CurvaFix about, is the bent axle phenomenon, where you have a bent, rigid rod within a bone. And if anyone has ever treated a femoral nail that's been placed in the past that didn't break from a subsequent trauma but bent, you can understand how painful that is to remove that nail. And I've done that a few times, and it is a long day at the office when you cannot get that nail out because of its bent, rigid structure. That's essentially what you're intending to impart in terms of the bone and stability with this implant. So that additional stability lends me to be a little more aggressive with weight bearing as well. Now, for this particular person with a right-sided SI joint and pretty comminuted crescent type injury, I protected him on the right, but I was able to let him go full weight bearing on the left. And even by the protection, I was letting him do stand pivot transfers for the first 6 weeks and then letting him weight bear after that. So just some examples of antegrade and retrograde anterior column fixation. So we're going to think a little bit out of the box on this one. This looks like a pretty benign injury. In fact, it's even hard to kind of pick out the injury on this x-ray. This is a 74-year-old who's probably physiologically 94. Her bone is quite thin. It's very fragile, and this is just a ground level fall. And I'm frankly surprised she didn't just have a run-of-the-mill hip fracture with how this looked. You really can't tell where the injury is when you look at this, but she was having a very difficult time mobilizing. She was unable to stand. She had some back pain. You can see her spine fusion there, but really she was relating this to a new pain from the fall, not able to mobilize with physical therapy. Now, on cross-sectional imaging, you can see on both sagittal and coronal plane imaging, she has essentially a crescent variant that really fractured and impacted right through the superior gluteal, superior side, the greater sciatic notch, excuse me, greater sciatic notch. And if you look at three-dimensional imaging, you can see that impacted injury through the iliac wing out to the iliac crest. It doesn't complete, actually, because her bone is so pliable and fragile, but it looks very buckled and displaced at the sciatic notch. Also, subtly, there is an anterior column injury to the pubic root on the right as well as the inferior ramus, which is a little more obvious to see. So for this particular case, I want them to be able to get out of bed. I want them to be under better pain control so they can mobilize. And I'm alluding to what Samir was talking about initially is I want to make sure this patient can be treated like a hip fracture. They can get up and go. They don't have to be in bed. And this person was not that. So essentially, I first tackled this by doing what I thought was the easiest plane first to tackle, which was the anterior column screw in an antegrade fashion. Again, using that guide wire to drive through and make those turns and bounce off the intact cortex and bury itself all the way to and almost into the pubic symphysis. And I think we'll see, or potentially see a little bit later, some actual symphyseal fixation as well. But for the anterior column in this particular case, first started with that antegrade CurvaFix. And then this is just to demonstrate how you can overlap implants and overcome a planned secondary CurvaFix implant within the same bony corridor. So looking at the top left image, we'll see that exchange tube that's radiopaque, where you have to take the ball tip out and put the smooth wire in just to demonstrate how that would look under x-ray. And then after that anterior column screw is in, we can start a standard LC2 corridor and use that wire, where you can see in the top right on the object inlet, and then on the iliac oblique in the bottom left and center image, how that wire can steer past, up and over that anterior column implant without really any problem. And then you can see on that obturator outlet view, where you're looking really up the pike, really that TP view in the bottom right, the implant kind of driving right up the sciatic buttress into the posterior superior iliac spine. Now, for this particular case, I wanted an additional augmentation of that posterior injury. And because she didn't have a complete fracture out the ilium and she was quite fragile and frail, I didn't want to make any larger incisions and get into any major blood loss. I did a corridor that essentially extends, similar to what Samir was talking about, start point on the gluteal pillar, and extended into the posterior superior iliac spine. So rather than taking down into the posterior column, you can actually drive this wire back into the posterior pelvis at the PSIS. And I drew the fracture line there so you could see in the top right image how we can get 2 implants past the fracture line. And in the center top image, just to know that because the driving end is a little bulky, especially on the 9.5 implants, you can have a countersink that drives into the iliac crest along the gluteal pillar. And you'll just see some representative images of what this looks like. First, with the actual insertion trocar, finally by the exchange tube getting down into the PSIS, and then followed by the final implant. So this is what the construct looks like for this particular patient, with 3 CurvaFix implants tackling each additional injury. The anterior column was relatively non-displaced, so staying within the boundaries of the anterior column in an antegrade fashion is quite simple with this. That posterior, more difficult, I think, fracture was able to be crossed in 2 planes by 2 rigid, bent, fixed implants, which really imparts significant stability to the injury. And I will say the challenge in fragility fractures with this or any implant, to be honest, is really the imaging and making sure that you take time to get good quality images so that you don't drive that wire out into a place you're not intending it to be. It can be really challenging to get good images, but I would just implore you to take some time and make sure you can see what you need to see and be confident in what you're doing. And finally, just some post-op images. I made this patient immediately weight bearing as tolerated. They were able to ambulate with a walker almost right away. That was their baseline ambulatory status, was just with a walker. So she was able to get back to that within the first 2 weeks and stayed that way up to the 8-month mark, which was my last follow-up with her, and just showing these representative images here.